Do you have a workout plan? What do you do?
Not normally, or not. It's not so normal now, but I used to. Maybe about a year back.
So there was a time period where you stopped working out,
Correct.
and then your pain started. But you were lifting weights before
I
that.
was lifting weights before all that happened.
Yeah, I think that's often an important part of the history because a lot of the weightlifters, they're focused only on the muscles that they can see. So they only work on their pecs and their deltoid and their biceps and their tricep, and then they forget everything else. So, and that's where they often get into trouble. So.
Okay. Yeah.
Ben, how about the location of the pain that he's having?
Point to where your pain is.
It's about here.
Okay.
If I kind of do this, kind of in this area.
Okay.
Is it front and back?
Can be back also.
Okay.
And the back part, is that in the shoulder blade area, or is he pointing the joint line?
Not periscapular. He's more posterior
Joint
glenohumeral joint.
And how about coracoid tenderness? Do you use that at all? Coracoid tenderness?
I haven't gotten there yet.
Okay.
I always palpate at the end because if I piss him off too early, I'm done.
And then finally, there's a lot of controversy on a lot of these tests, like O'Brien's test, how effective it is, and Speed's test. And so how do you place those? What's your hierarchy? Which one is your money test, and which one do you discount?
Let's talk about that after.
Okay.
Okay, because I'm going to do some more. I've not really tested for stability. I just had it in the 90-90 for impingement. And then while I'm there, I'll get a little preview. Mark, give me a hand with the table, please. So the next thing I would do is just have him lie down. And let's just move it over this way. And we've got to be set up to the camera, right? No, you're good, right there. Okay. Not sure what the surprise is under here.
It doesn't look comfortable.
That was going to be the padding that you were going to lie on, I guess. But, okay. So let's just have you lie on your back with your head up this way. Yes, please. So as long as there are therapists here, and I have to be a purist, I've got to put his elbows on towels, because otherwise Shirley Sarman will throw me out of the group. Okay, so I'm looking at what's the position of his, are we okay, you okay
Yeah.
angle-wise? Okay, so I'm looking at the position of his humeral heads, and then it's not bad, but that's how I'm going to look to see if his pec minor is tight, and a little bit on this side, nothing terrible. Not much more here. So that's pretty much the same. So then when I have him in this position, then I'll go through my provocative test. Actually, what I'll go to next is to see if I think, and I don't think there's going to be much here with Francis, but I'll see what's tight and what's not tight. So if I want to feel his lats, I want to make sure his humeral head is centered in the glenoid, and I don't do this with every patient. You've made me defensive, Pat. So his lats are pretty tight. I mean, that's as far as I can get him. His scapula is, it's hard to see, but his scapula is starting to wing, so his serratus anterior is tight. If I hold his scapula down, that's it. And then if I bring him and rotate him out and he goes more, that's teres major. So his teres major, his lats are tight. His pec is pretty tight. So this is all the stuff we usually see with people who do a lot of lifting, as Pat was talking about, that early looking up front. And boy, his subscap is really tight too. So all of his internal rotators are tight, but he has normal external rotation. He has full internal rotation. When you look for glenohumeral internal rotation deficit, you've got to make sure that you're not holding down the humeral head, because that'll affect rotation. So usually from the top of the table, I'll have my hand over this way, and then so I don't even have to go to the other side to compare, because he's got full internal rotation. And then from here, I'll do his apprehension, which I've already cheated and done before, so I wouldn't repeat it. Couldn't push forward. That's okay. So you don't have to do relocation tests or apprehension suppression, which is slide over towards me a little bit. I would just test him here, and if he was positive in that position, I'd push him posteriorly and then do the same thing and just have him push forward. And I want to eliminate the posterior pain that he had. So it's a relocation or apprehension suppression test. And then from there, the other test that I use for SLAPs is a passive distraction test. So, and we can talk about this later, but I put them into the overhead position at least 150 degrees, arms in extension. So I think I've got the biceps out at length. And then pronate. Pain there? Okay. And so that to me has been as good as the O'Briens. So I think, the literature, other than what Steve O'Brien showed, the literature shows it's about 65% accurate. I was sure that the passive distraction test, when I came up with it, was great, until I reviewed the patients that I had scoped, and it was 65% accurate. If I have a negative O'Brien's and a negative passive distraction test, statistically, that patient has a 90% chance of not having a SLAP lesion. So those are the two tests I use. Okay. And then from here, I go to, let me have you lie on your right side, left side rather. Head on there. Then I'll go into the lateral decubitus position, and this is how I examine instability in this position. Sorry that the mic box is in your back. Just relax your arm. Just go real loose. So the cue that I'll use for a patient is just a piece of overcooked pasta. Just let it hang. And then there's a reproducible click right at about 4 o'clock. And I've gotten in the habit of doing that in the operating room, where I'll say, this is what and say out loud, I'm feeling a click at, or he's unstable at, and what's happening with external rotation. Because if you've said it, then when you look inside, you can't say, that's what I thought. Yeah.
Ben, why do you do this in a lateral decubitus as opposed to supine position? Do you feel like you stabilize the scapula supine and you can free that up?
I think I can stabilize the scapula better if I'm holding it on both sides. And then I can go through more rotation. And also, when I do it in the operating room, I'm going to be able to reproduce it. So in this position, was that painful when I did that? Okay. He's not going to let me have it again. Just go loose, please. Okay, so he's going over the edge, and when he comes back, there's a click every time. And when I externally rotate him, it's about the same. But I think that's laxity. I don't think that's instability. And there's a little bit of posterior laxity. I didn't get him sitting yet, which I usually do on the way down to this. But he's got some posterior laxity, so I've got to compare sides, and I have to do a sulcus. I'll do that sitting. So,
Ben, what's been the relevance of a click like that in your experience?
then I'm thinking he's got labral pathology, and he's the right age to be thinking about that.
And have you found that correlates from an arthroscopic standpoint, just as a gestalt?
Most of the time, but not always, because sometimes there'll just be a little redundancy that you see arthroscopically, and then, because there was a paper, Bill McMaster a number of years ago had 4 swimmers that he scoped and took off a little bit of stuff over the labrum and said that was the problem, and it was published, so people started believing that. So flip over the other way, please. He's got more laxity on this side, but no click. No click, no grind.
Did you say more on the left?
More on the left, yeah. But more anterior, but less posterior. Okay, so that exam. Come on and sit up if you would. And come on, stand up for a minute. I just want to move the table around so you don't have to stand on the end. Yeah, I think that'll be fun. Come on and just sit here if you would, please. Yes, facing forward. Thanks. And then the sitting exam, the load and shift exam, I'm going to, again, he drops into that posture, but he doesn't have much in the way of sulcus in neutral. Certainly not anymore.
Do you tell them to sit up straight when you're doing that? Do you try to get them to get into correct posture?
I'll do it this way first, and then I'll have them.
Okay, but so you do both?
Yeah.
Okay.
If there's no instability this way, I tend to, I sort of pick my based on the history, I'm
Okay.
picking what I'm doing. And then stabilizing the scapula, he's got a little bit of posterior laxity here. Is that okay? Okay. And that's okay. Okay. So, not much instability. No instability. There's not much laxity. Actually, a little bit more of a sulcus on this side. And less posterior laxity here. And now in this position, less anterior. So, and then I palpate, and then you sort of pick where you're going to palpate. He has no symptoms around his scapula, but I'd go AC joint, I'll go biceps, and if I hit a spot that's tender, tell me. Is that one? Oh, no. Okay. And then to get rotator cuff, put the arm behind the back to bring the greater tuberosity out from under the acromion. No. Okay. Tender there. Okay, a little bit on the coracoid process and pec minor insertion. There. But not on the other side. So that has something to do with it. And the only thing I didn't do, elbow here, hold your hand right there. And now just rotate your hand. Keep your elbow where it is and just rotate like you're throwing. So I'll feel for crepitus usually when I have him in this position. There's a little bit. Okay. So now, I've not identified his problem. I think he's got some posterior laxity. I think he's got scapular dyskinesis. I think he's got some a scapular control problem. But if I had to give him a diagnosis now, let me not say that. What other stuff would you do? What diagnosis would you guys? I don't want to make it as a test, but
Well, no, I think that's accurate. I guess, Mike, I would redirect it back because you did identify scapular dyskinesis and this click in the labrum, but you don't have a traumatic etiology or, so my thought is maybe the click, or how much is the click a part of the problem, or is it dynamic? And so my next question would be, what would be your next step? Are you going to go to an MRI? Are you going to send them to Mark? Just do